Assalamu alaikum. Thank you, Majid, for the presentation. The organizer and Eli Lilly for allowing me to talk about the CDK4/6 inhibitors now. It seems like you guys are now going to be bored by this is the third presentation about the CDK4 and 6. I'll try to be brief and to the point. I would like to highlight some of the differences between the agents. Uh, I, for some reason, I cannot move the slides. Would you allow me to um, okay, so somebody else is going to move the slides for me. Fair enough. Okay. So this is my disclosure today. This is a sponsored talk by Eli Lilly. And on the agenda, we have the background. Uh, we'll talk quickly about the first line in one or two slides. And then in the second line, we'll talk about the couple of slides on the second line, then moving on to the special situations. Next slide, please. So this is the barcode on your right side, and on the left side is the link. We have a couple of voting questions, so if you don't mind, please scan the barcode or click on the link to be able to join us for the polling. Go ahead to the next slide, please. All right, so what's your specialty? Very difficult question. So medical oncology, pharmacy, pharmacist, nurse, and surgery. All right, 100%. By the way, there you go. We have competition from oncology also. Okay, a couple of minutes and okay. All righty. So the first, thank you very much. So the question, the next polling question is: are all CDK4/6 inhibitors, are they the same from the presentations that you have heard of from your experience? Do they different? Do they have a difference in mechanism of action, or they are only different in the safety profile, or maybe they are different in both mechanism of action and safety profile, or the fourth choice, which adds a difference in unfavorable prognostic factors like endocrine resistance, visceral or liver metastasis. So please pick one of these four choices. Okay. So excellent. So they do have, so the group here, they think that there's a difference in mechanism of action, safety profile, as well as difference when it comes to unfavorable prognostic factors. Excellent. I wasn't expecting this. Okay. So moving on to the, I'm sure you have seen this slide before. The RB gene is a master regulator of the cell cycle. When the RB gene is a tumor suppressor, so if it's active, it prevents the cell from progressing from G1 to the S phase on a point called the R point. What happens when the RB gene is phosphorylated or hyperphosphorylated, it becomes inactive. And when it's inactive, then the cell can freely move from the G1 to the S phase. Now, cyclin D with CDK4 and 6, they form a complex called, for obvious reasons, cyclin D CDK4/6 complex that hyperphosphorylates the RB gene, and it essentially inactivates the RB gene. And that's why it's important to use agents to inhibit CDK4/6 inhibitors to allow the RB gene to be active. Moving on. So, and it does make sense to combine the estrogen inhibitors or AI and fulvestrant with the CDK4 and 6. The reason is that CDK4 and 6, they are a downstream signal in the pathway of the estrogen pathway. So it does make a common sense to inhibit the pathway from above and below, with agents that will suppress the estrogen pathway from above, like AI and fulvestrant, and the CDK4/6 from below. Next. So these are the three agents that you were bombarded with in the previous presentation. If you click, please click one click on the slide. So it shows you here that the palbociclib and ribociclib are somewhat physically similar in terms of physical property. Abemaciclib is a little bit different in terms of the physical property. Next. So not only it's different in terms of shape and physical property, but it's also different in terms of affinity to CDK4 and 6. For instance, abemaciclib inhibits CDK4 14 times more than the CDK6. And it's worth mentioning that the CDK4 is available abundantly in the GI system as well as in the breast tissue. And that's exactly why you have side effects in the GI with the Abema more than the other agents. And CDK6 is available abundantly in the bone marrow and in the breast tissue, and that's why you have more neutropenia with ribociclib and palbociclib compared to the abemaciclib. Next. So the other thing that will maybe is more important here to the pharmacist is the dosing. Now, abemaciclib is given in a BID form with a continuous dosing. So there is no break in the dosing as opposed to palbo and ribo. The reason behind that is that it's a dose-dependent or concentration-dependent inhibition. So the more drug available in the system, this is on the cell line, the more drug is available in the cell line, the more inhibition there is. And when you look at the right side, you see that the RB gene, which is the whole idea of giving CDK4/6, is to make the RB gene more visible, right? So when you look at the first line, is that really it's a dose dependent that inhibits more CDK4 and 6 and allows the RB to be more visible, which is visually seen in the first line. Next. When it comes to the IC50, as well as we know that they're all these are all oral medications. Dosing is continuous in the abemaciclib, while twice a day, while it's once a day in palbo and ribo. And we know that with ribo and palbo, we stop the medication for 1 week, while we give abemaciclib continuously. Now, some see this as an advantage, some see this as a disadvantage. Obviously, twice a day medication is considered to be a disadvantage for compliance. And then the other thing is that the 1 week off may be confusing to some patients, but some see it as, well, it's a break from treatment. So this is more an open discussion, but this is how it is. Okay, moving on. Next. So CDK4 and 6, these are the slides that summarize the whole story of the CDK4/6 inhibitors, second line, first line and second lines for the 3 agents. Next. Next. So I said that I will really have few slides on the first line, and the reason is that the first line trials, Paloma 2 for Palbo, Mona Lisa 2 for Ribo, you just heard about, and Monarch 3 for Abemaciclib, the primary endpoint was progression-free survival. The secondary endpoint, except the Mona Lisa 2, did not include overall survival, but they basically, the primary endpoint is the same, secondary endpoint is very similar. And next. And this is what happens is that the progression-free survival with a hazard ratio for all of the first-line clinical trials is essentially the same, honestly. You look at the hazard ratio 0.56, 0.58, 0.54. When you look at the difference in terms of progression-free survival is almost 10 months in all these clinical trials. So we'll just leave it there. I'm not going to dwell on the first line, and you have heard of the information about the other and the other trials. So this is going to be our first line 2 slides. Next. So let's talk a little bit more in the second line. Next. So the second line, few things that we need to really define because it's important to understand the second line a little bit more in detail. The number one is the definition of hormone resistant. We'll talk about it in a minute, but this is something that we need to be aware of, as well as patient selection. So in PALOMA-3 is a second line for palbociclib. Palbociclib is one of the earlier medications, the oldest among them. So PALOMA-3 was published in 2015. This is almost 6 years ago. They enroll patients who have had hormone resistant and hormone sensitive and chemotherapy. They allow these patients to be enrolled. So this is considered to be a heavily pre-treated patients. Historically, we know heavily pre-treated patients tend to underperform in the clinical trial. So they randomize patients to palbociclib with fulvestrant versus fulvestrant alone. And the primary endpoint was a progression-free survival, and the secondary endpoint was overall survival, among others. Next. So it did really, next slide, please. Can we move to the next slide, please? Okay, so what happens is the progression-free survival with the PALOMA-3 showed a significant improvement, almost doubling of the progression-free survival from 4.6 to 9.5, and that was the primary endpoint and really did meet the primary endpoint. Next, the issue is that the overall survival wasn't really positive in PALOMA-3. Can we move to the next slide, please? And the reason is, as we discussed earlier, is that the heavily pretreated patients tend to underperform in the clinical trials. They try to look as the unstratified patients, the unstratified cohort. So the hormone resistant patients tend to become more. Can we move? You move to go back one slide, please. I'm sorry. So the hormone resistant patient, which is the unstratified hazard ratio, was positive, but in general, this considered to be the primary endpoint wasn't met by the clinical trial. Okay. So the other clinical trial, which is the MONALEESA-3, we have a delay, guys, on the slides. I'm not sure why that is. If you allow me to share my slides, it will be more convenient if you end this sharing slides, because it's kind of become a little bit more. Can you end? Yes, please. Let me share my screen, and I'll use my. Yeah, thank you very much. Just give me a second.
You can share your screen now, Doctor. Please make it full screen.
I will do that. Give me a second.
Thank you.
All right. So the second, the phase 3, the second trials, phase 3, the MONALEESA 3, which has been discussed by Dr. Adhar Sayed. I will not dwell on it. I will just say that the Mona Lisa 3 really showed benefit in the first line and second line. I will argue that the definition of the second line or early relapsers did not really follow the ISMO guidelines or the current definition of the early relapser or the hormone resistant. But the overall survival was also positive in the intention to treat analysis. So with a deep p-value. Now let's move on to the MONARCH 2, which is Abemaciclib with fulvestrant this time. So the definition here of the hormone resistant and hormone sensitive, we'll come to it in a minute, is followed the guidelines, the ISMO guidelines, so it's more clear who is resistant and who is sensitive. They did not allow patients to use chemotherapy, so one line of hormonal therapy only. Obviously, HER2 negative, hormone positive, and then there's a stratification factors including metastatic site, the hormone resistant, and they followed patients on close to 47 months. Randomization, obviously, to Abema and fulvestrant versus fulvestrant alone. The primary endpoint is progression-free survival. Secondary endpoint is overall survival. The exploratory analysis is time to chemotherapy, as well as the stratification by menopausal status. Now, the primary endpoint, which is progression-free survival, is positive. It added roughly 7 months to the progression-free survival, as well as 9.4 months in the overall survival, with a hazard ratio of 0.7 and a positive p-value. So when we look at the stratification point, it's really important to know that these are pre-specified. So these are things that the design of the clinical trial, they wanted to look because they thought that they have advantage in certain situations. They thought that, okay, maybe we, in visceral metastasis or in primary resistance, the medication is more effective. So we need to pre-specify that and look at it. And certainly in visceral metastasis, if you look here on the visceral metastasis, it showed that the medication is more effective than in bone-only disease in terms of the hazard ratio as well as the confidence interval. And then when the primary resistance, when they look at the primary resistance, the hazard ratio is better, but the confidence interval is not as good as in the visceral metastasis. But again, the definition of the primary resistance is a relapse within 2 years of the adjuvant therapy or progression within 6 months of the first line endocrine therapy or while on the endocrine therapy. So that's the actual definition of it. So if you don't fall into that category, then you don't have a primary resistance. And the reason why this is important is that because if you have visceral metastasis versus bone-only disease, look at the hazard ratio. Visceral metastasis is 0.6, while the hazard ratio in bone-only disease is 0.9. So it's the medication, this analysis suggests that the medication is more potent in patients with higher risk, as you guys all know and voted for initially. Now, when we look at the primary resistance hazard ratio also and the graph, it showed obviously that the Kaplan-Meier curve showing primary resistance, more benefit, more separation of the curve between the placebo and the Abemaciclib arm compared to the secondary resistance. That also translates into the hazard ratio 0.68 versus 0.78 in the secondary resistance. So again, primary resistance, visceral metastasis, more effective Abemaciclib than the fulvestrant alone. Now, the exploratory analysis, which is time to chemotherapy, one of the outcomes that the study wants to measure is that does chemotherapy significantly be delayed with the use of Abemaciclib? It did, hazard ratio 0.6. It almost doubled the time to start chemotherapy, which is one of the things that patients tend to want to avoid is chemotherapy. Although sometimes the chemotherapy, I would say Dr. Athar Said mentioned that everolimus, for instance, is one of the agents that we use after the CDK4/6 inhibitors to delay chemotherapy. But I find everolimus have side effects really terrible. It's almost as bad as chemotherapy. But these are things that we patients try to use oral medication, non-chemotherapy medication. So the study wanted to measure that objective. Now let's take a look at the side effects. The major side effects that abemaciclib is notorious to do is diarrhea. So diarrhea in 87%, mainly grade 1 and 2, so grade 3 in 14%. And usually diarrhea is managed by loperamide, and it happens in the first month. And it's not something that we tend to discontinue the medication for commonly. It's because it's really easily manageable. And we do have a couple of patients on abemaciclib as part of clinical trial that we are participating in. Not metastatic, it was in the adjuvant setting, and really diarrhea wasn't a big issue. Now neutropenia happens in 50% of the time, so it can happen in abemaciclib. It's more with the other CDK4/6 inhibitor, but definitely it's one of the major side effects with abemaciclib. Now that said, I don't really find neutropenia to be a bad side effects for CDK4/6 inhibitors in general. This is a patient of mine who, if you look here, this is a full year, almost the entire year is neutropenic. This patient we did not dose reduce the medication. We did not hold the medication for this patient. The reason why she came in with neutropenia, and if we will not treat her if we will follow the guidelines completely, this patient wouldn't be treated with CDK4/6 inhibitor. I do have slides on this patient. This patient enjoyed an excellent response. Never been admitted for febrile neutropenia. Despite that, we really continued the medication with this patient received, by the way, palbociclib, but we didn't even dose reduce. And the reason why I want to put this here is that because it's really common in Saudi Arabia that we have what we call benign ethnic neutropenia, where patients will start with neutropenia at baseline. So if you want to follow the books and the guidelines, you will not treat these patients with palbociclib. This is not an invitation to give palbociclib randomly, but I wanted to show you that if patients have low neutrophil count to start with, you may end up not sticking to the guidelines for these patients if you want to treat them appropriately. The other side effects for CDK4/6 inhibitors is alopecia. It tends not to be mentioned in the discussion with patients. I personally used to kind of ignore it before I received this patient. This is considered to be, by the way, a grade 1 alopecia. This is patient on CDK4/6 inhibitor who developed alopecia. Patients are very much concerned about their hair. When you not give them chemotherapy, when you don't give them chemotherapy, you almost give them the hope that they will not lose their hair. We know that the CDK4/6 inhibitor may, this is rare, but it's one of the side effects. This is actual patient whom I took a picture in the clinic. One of the other things, Dr. Al-Hassaid mentioned the interstitial pneumonitis, and I also would like to add DVT. In side effects, one of the side effects for CDK4/6 inhibitor and more in abemaciclib is the VTE that happened in MONARCH 2 in less than 4%, if I remember correctly. Now, let's move on to the special situations. We also, Dr. Sayed spoke about Mona Lisa 7 One of the things that I would like to mention here is that in Mona Lisa 7, obviously this is a premenopausal study. So all of them, they were rendered menopausal with goserelin. So whether they took tamoxifen or not, or AI, they had to have goserelin. So biochemically, they are menopausal, but the age-wise, they are premenopausal. One of the other things that the tamoxifen increases the QTC, as you guys know, and the also ribociclib prolongs the QTC. So the combination of tamoxifen and ribociclib is not favorable in this situation. In Mona Lisa 7, the hazard ratio was 0.5, and the progression-free survival also added 10 months. As you remember that we said, all of them in the first line added 10 months, and the hazard ratio is 0.5. So this is a replication of that. But the advantage here is that the overall survival in the first line was positive with in Mona Lisa 7. Now, you remember that I told you that in Monarch 2, one of the exploratory analysis was in the exploratory analysis was for pre and perimenopausal women. Certainly, they included 16.1% in the abemaciclib arm were peri and premenopausal patients. And the exploratory analysis, I'm sorry about the resolution here, it shows that the premenopausal women enjoyed a deeper response with a hazard ratio of 0.6 compared to the postmenopausal woman with a hazard ratio of 0.7. So this is, again, exploratory analysis, but it showed that the premenopausal woman may benefit more with abemaciclib. Finally, the heavily pretreated patients, the Monarch 2 is the use of the abemaciclib as a single agent, this time 200 milligram BID instead of 150. And this is a single arm to evaluate abemaciclib with respect to confirm objective response. The idea behind the drug is that after you receive multiple lines of treatment, including one or more chemotherapy and multiple hormonal agents, that you use single agent higher dose of abemaciclib to induce response in these patients. And in general, these patients, these are the most heavily pretreated patients, with almost all of them have liver metastasis. Majority, like more than 98% of them, have liver or lung metastasis. Bone metastasis only is in 2%. And most of them have more than 3 sites of metastasis. And as we said, 100% of these patients
Ahmed,
had...
sorry for interrupt. We have 1 minute. Just
Sure. I'm about to finish.
yeah.
I'm about to.
Thank you.
So this is the confirmed objective response rate, which is 19.7%. That allowed the clinical trial to be registered for a single agent use in heavily pretreated patients. The progression-free survival was met. The overall survival was 22 months, but this is no control arm. But this is a real world survival outcome. This is a Hope Rojo, one of the famous breast oncologists, who wanted to provide a control arm for Monarch 2. And because of the time issue, I will just show you that this is the comparison between the real world in blue and the Monarch 1 in red. That showed a hazard ratio of 0.5 with Monarch 1. And the conclusion from the trial is that suggests that there is a survival advantage, possible survival advantage of abemaciclib as monotherapy in these patients. So the answer was 100% for this polling. So I will not go for the polling again. I'd like to thank you for listening to my lecture, and thanks for the organizers for their patience and the invitation. Thank you very much.